focusing on the structures that keep people in poverty. Our network is comprised of 32 Catholic religious congregations whose members have lived and they have worked throughout Africa for generations. We provide a unique foundation for informed advocacy and solidarity with African communities. We are especially pleased to partner in this event with AdNA, a non-partisan coalition of organizations, of which AFJN is a member, and individuals committed to strengthening, they are individuals committed to strengthening US-Africa relations, advancing African-centered approaches to policy, to development, public health, and social justice. Together, we are honored to convene this discussion at a particularly important moment. As communities in East and Central Africa confront the challenges posed by the current Ebola outbreak, there is a growing need for informed dialogue, which centers the experiences and expertise of those closest to the crisis. So today's event offers an opportunity to better understand those realities on the ground, the ongoing response efforts, and the lessons that can strengthen public health preparedness and international solidarity moving forward. We are particularly privileged to be joined by two distinguished panelists who are working on the front lines of the outbreak in Uganda and DRC. Their first-hand experiences and expertise will help us move beyond the headlines and to be able to gain a deeper appreciation of both the challenges and the resilience of affected communities. We are grateful to them, and therefore we're also grateful for you who have joined us, which reflect a commitment to learning, solidarity, and engagement with issues that affect Africa. So to guide us through today's discussions, it is my pleasure to introduce Mr. Ntama Bahati, who is AFJN's policy analyst. Originally from the Democratic Republic of Congo, he brings valuable regional knowledge and policy expertise that make him exceptionally well-positioned to moderate today's conversation. Bahati, thank you for leading us through today's discussions. I now invite you to take over, introduce our panelists, and begin the program. Thank you again one more time. God bless.
Thank you, Dr. Rogers. I'd like to introduce our first panelist, Dr. Sengi Damabialiro. Is an associate professor, Faculty of Medicine at the University of Kinshasa. Dr. Sengi is head of the Department of Basic Science and professor of pharmacology and pharmacoepidemiology at the University of Kinshasa. He has extensive experience in infectious disease research, pharmacovigilance, and clinical trial in the Democratic Republic of Congo. His work has included the service on the pharmacovigilance working group for randomized clinical trial of anti-Ebola therapies, leadership in Mpox drug trial pharmacovigilance, and principal investigator work on Mpox vaccine safety monitoring. He collaborates with the national and international partners on therapeutic, drug safety, and epidemic-prone disease. Dr. Sengi, welcome. I'd like to invite you, Dr. Sengi, to go ahead and make your presentation, and I will introduce Dr. Alice before she makes her remarks. So, Dr. Sengi, you have the floor.
Yeah, thank you very much for this wonderful presentation. I'm very honored to have this opportunity to present on this very important session. So if you don't mind, I would like to have the possibility to share my screen. Let me check if this is possible. Okay, it looks like this is possible. Share the screen. Yeah. Thank you. Can you see my screen?
Yes, we can.
Okay. So yeah, I'm going to talk about Ebola virus disease in DRC from the perspective of what I've seen. Yeah, this is some kind of disclaimer. So I've been using different tools, but also draw from my experience during the North Kivu Ebola Ebola outbreak and Mpox outbreak and the others. So my objective is just to share knowledge and to try to understand the challenges for managing Ebola virus disease in the context of DRC. Yeah, I want to apologize for my English. I'm basically French speaking, and in the evening, like now, English words like to fly out of French speaking mind. So if there are difficulties, I apologize in advance. Okay, this disease was formerly known as the Ebola hemorrhagic fever because people thinking had hemorrhage and fever, but now we know that we do not have always hemorrhage or fever, so the name changed to be just Ebola virus disease. And the name Ebola comes from a river in DRC actually, which is close to the village of Yambuku, which was the place where the first case was discovered in the 1970 years, 1976 actually. So you see all the Ebola virus that exists up to now, and the names have been changed from 2023. So we have this Ebola Zaire, which is the most dangerous one. And we have this Ebola Bundibugyo, which is now the BDBV, which is, yeah, also severe, but not as severe as the Zaire strains. The transmission, it comes from animal, actually from bats. But when there is an outbreak, transmission is mostly human to human transmission when people are in contact with blood or body fluids of people who are sick, even in contact with dead bodies of those people, can contaminate people. This is a very big summary of pathophysiology. I'm not going to go through it, but we see all the mechanisms that lead to the bleeding, to the fever, to the multi-organ dysfunction, which is a very severe condition that leads to death of the patient. When people has the disease, so when the people is contaminated, we have an incubation period that range from 2 to 21 days. And we have different phases. On the first 4 days after contamination, people have fever, severe asthenia, headache, myalgia, and arthralgia. Then we have the second phase, which is gastrointestinal phase, which goes up to approximately 1 week, in which the patient have vomiting. This makes it difficult to have medication that are orally administered because these people vomit a lot, and I've seen that many times when I was on the field. Systemic phase, when the people are dehydrated, they have hypotension, tachycardia, and then the general condition deteriorates rapidly. Then we have the severe phase, people are in shock. We have neurological disorder, renal failure, and hepatic failure. This is a very severe stage because during the outbreak in 2017, 2018 in North Kivu, when we were implementing the clinical trial, we have people who have been treated. PCR show that there are no more viruses in their blood, but they still die because they came when they were already in the severe phase. The renal failure, hepatic failure were so damaged that even when the patient were cured from Ebola, the complication of Ebola still killed them. Then we have sometimes in some patients hemorrhagic manifestations. I want to share about the characteristic of the BDBV, which is the current outbreak of the Bundibugyo. Bundibugyo virus is less virulent than the Zaire virus. As we can see, currently, as of the 8th June, the death rate is around in DRC is around 19.2%. I think if we combine with the death rate is slightly lower in Uganda. But if we compare to the most recent outbreak in North Kivu, the death rate was 66%. So you see, Bundibugyo is not so severe, but still severe. 20% of death is still something, a very high death rate. So what do we have to treat this disease? Yeah, first of all, I'm not going to talk about it. It's difficult to develop drug against Ebola virus disease, because you do not have the disease all the time. Disease appear in the form of highly deadly outbreaks. And you have patient for a moment, almost all of them die, and then you do not have patient anymore. So it's difficult to develop drug for Ebola virus disease. For the treatment, the first and the most important treatment for Ebola virus disease is supportive treatment, rehydration, and aggressive rehydration, because these people are vomiting, they have diarrhea, they are losing fluids from their body. So we need to give them fluids to correct all electrolyte disturbances, provide oxygen therapy. I was talking about multi-organ dysfunction. We have trouble in the respiratory system, hepatic functioning, renal failure, etc. So we need to compensate for all those difficulties. So we need oxygen therapy to manage shock, nutritional support, and also these guys continue to have all the current infection that we have, malaria, typhoid fever, etc. So we need also to manage all those secondary infections. Most importantly, these measures remain the principal determinant of survival for many patients. And you can see we have only, I would say only 19.2% of death, but this is mainly due to these supportive measures. Approved medication for AVD are only for the Ebola Zaire strain. We have the Ibanga, Ansuvimab, and Inmazep. Actually, I was working as safety physician during the clinical trial that provided this drug. We have also a vaccine. We were all vaccinated since we were going on the field, but all of them are approved for Ebola Zaire. But all these drugs, I will talk about ring vaccination later, all these drugs do not work on Bundibugyo virus, because the only target of this drug, which is the GP, the glycoprotein of Ebola, is similar in Bundibugyo and Zaire, but the small differences make that protein to change in the conformation, so that the target of the drug or vaccine are not accessible anymore. So this drug for Ebola Zaire will not work for Bundibugyo strain. So I wanted to talk about vaccination. Vaccination, what we do is what we call ring vaccination. If we have one case, this is the guy in red. This guy do not need vaccination anymore because he is sick, he needs medication. What we do is to vaccinate all the people who were in direct contact with him. These are the guys we call contacts of the patient, direct contacts. Then we vaccinate contact of the contacts. For example, we had one pastor who went to preach in those contaminated zones and said he could cure with prayer all the people who were sick, but he got contaminated and many people were contaminated with him. And then he came back to Goma in a bus. and then we saw that he developed the disease. What was done is this guy received treatment. All the people who were in the bus with him, people who were in the church with him, were the contacts. We searched for them and they were vaccinated. Then after the people who were in the bus went home, and the people of the family of those people are the contact of the contact, and all of them were localized. There were about 162 persons, if I'm not mistaken, and all of them were put together and vaccinated. This is what we call ring vaccination. And I was saying, this is the structure of Ebola virus. It had only one glycoprotein at the surface, and this glycoprotein is essential for the infection and is therefore one of the principal target for vaccine and drugs. And I was saying this is somehow different in BDBV, which is the Bundibugyo strain. So medication for Ebola Zaire will not work on the BDBV. What do we have as of now as potential treatment? We have this kind of pan-Ebola virus monoclonal antibody that targets some section of that glycoprotein who do not variate, who do not change, which do not change in different strains. And these ones are being tested, are priority for clinical trial by WHO. We have this one being trained in, we have clinical trial of this MBP134 in DRC. We have also maftivimab, which has been also in clinical trial. We have remdesivir that have been tried against Ebola Zaire, but did not work well. Tried in COVID-19, did not work well. But now we think it may work, but as a post-exposure treatment. So there's a clinical trial. We have meeting for now. I'm involved in two of these clinical trials. The first one and this, not the remdesivir, but the obeldesivir treatment, which will be used for post-exposure prophylaxis. So people who have been exposed to Ebola patient will receive this drug, and we'll look and we'll check if they will be protected against Ebola. So these are the candidates being tested on the field to see if they will work on the BDBV. So now let me share with you the challenges, and they are so many. The first one is diagnostic capacity. You know, the diagnosis of Ebola is clinical, yes, but we need confirmation by laboratory testing, and we need very expensive devices, just need to be carried to those forests with no transportation system, with no electricity. So we need to set up something. Actually, there is a paper that we wrote with our colleagues from NIH about the challenges in setting up the laboratory in those conditions. And this is a very important challenge. We need to provide electricity to have a very strong logistical system in place. The other issue is availability of treatment, of course, but also the management of these drugs, the investigation of product. You need cold chain, you need logistics, and this is many times challenging because I was saying we do not have electricity. Sometimes those devices providing electricity fall down, and you have you need to have backup like solar panel and so many things. It's challenging. Also, infection prevention among healthcare personnel. You know, this kind of protective equipment. I will show you just a picture. We need to follow up the contact of the cases. If somebody is sick, you need to find the contacts and follow them up. And up to now, the last data, the only 56% of the contacts are found. The other fly away, they run, because they fear that you will put them in those centers of treatment and potentially die. So we need to follow up all those contacts. And we need community acceptance. So this is why we have social people specialize in sociology, in psychology, in community psychology, in order to understand how the community works, what are the customs of the community, so that we can work with them and make the intervention acceptable to them. We need a strong coordination because you will have multiple stakeholders, WHO, NGOs, the government, the hospitals, etc. And if coordination is not very good, everybody will be doing their own thing, and you will end up losing control and not knowing what you are doing. This is a very important challenge as well. And I was talking about considering socio-cultural factors, how people bury their dead ones, and take into account all those in order to provide a way of burying people that does not promote contamination. This is how Ebola treatment center looks like. We have the green zones, the red zones, etc. Yeah, I can answer to questions if somebody wants to understand more about that. So now some pictures. This is the green zone where the healthcare people are staying, and this is the equipment that people need to wear. I can tell you, you are suffocating down there. When you are wearing on this thing, it's very hot and it's difficult to treat patients. So it's very difficult to use this equipment. So as a summary, you need a team that is multidisciplinary, it's dynamic, committed, and accepted by the community. This is very important. This is some of the image from the previous outbreak. We were in the red zone. You can see I was much more younger. You can see it. That was in Katwa, the second one in Beni, and this one was in Mangina, where actually another challenge specific to DRC is armed group. And we had some health personnel who were killed actually in Mangina. And you can see we are smiling on this picture, but this is just for the picture. We were really frightened, and because every night we would think maybe somebody will come to kill us. So yeah, these are some of the challenges and what I can share with you about Ebola virus disease in DRC. Thank you for listening to me, to my bad English, and yeah, thank you very much.
Thank you, Dr. Sengi. I am very, very sure that your English was well understood. It's perfect.
I hope so.
We'll be taking questions after Dr. Alice has presented. So I see some people are writing questions. So let me introduce Dr. Alice. Dr. Alice Lamwaka Veronica is a senior lecturer of the Faculty of Medicine, Department of Pharmacy at Gulu University in Uganda. Dr. Alice is a senior lecturer of the pharmacy at Gulu University whose work bridges laboratory science, clinical care, and health policy. She chairs the scientific committee of the 4th National Test and Treat Initiative Conference and has led more than 15 years of community-based research in post-conflict northern Uganda. Her advocacy centers on Africa-led sustainable health solutions that strengthens public health systems and places local expertise at the center of the response. Dr. Alice, welcome, and you have the floor. I'm gonna be sharing her PowerPoint.
Thank you.
Let me see, where is the share button? Let's see, share number 2, speed 2.
Welcome, Dr. Alice.
Okay.
Thank you.
Can you see the
Share.
Can you see her document, her PowerPoint?
Okay. Not yet.
Not yet. Let's see. Select two. Second, let me see what.
If you email it to me, I can share. If
share.
Would you like me to share?
Let's see what is going on here.
So for those who have questions, if you want, you can text the questions and we'll read them when it's question time. But also, once the presenters are done, you can raise your hand and we'll take the questions as the hands have been raised and in the order in which they have been raised.
Right.
Thank you so much.
For some reason, it is.
If you email it to me, I'll try to share while she's making a presentation. So while we're waiting, do you want us to go to Q&A for Dr. Tambialiwa? Okay. All right. So what I can do is we probably would maybe do one or two questions for the presentation while Bahati is trying to get him the technical side. You can raise your hand. Okay, I'm going to go with Regina. Could you ask?
Yeah, thank you, Doctor, first of all, for the great work that you are doing. And I want to say your English is perfect, you know, and
Would you tell us like where you're calling from, or I mean, who you are? Just one line.
Okay, I'm in the US in Pennsylvania.
Okay, go ahead.
Yeah, okay. So my question is, you give the vaccination when the people have been contaminated or they have come into contact with somebody who has the virus. And I'm wondering, why wouldn't you vaccinate everybody as soon as you realize that there is an outbreak, rather than wait to trace the contacts to give them the vaccines?
All right. Thank you, Regina.
Yeah, you're welcome.
Doc, do you want to go with that? You're muted.
Okay. Yeah. So this is a very important question, and this is the ideal situation to vaccinate everybody. But we have two elements. The first one is the availability of the vaccine. Now, actually, many people are working in the way of providing vaccine to everybody. Sometimes we do not have enough vaccine for everybody, or we do not have. Maybe we have enough vaccine here in Kinshasa. Somebody asked about the map. I will show you the map where the outbreak is now is about 200 kilometers from Kinshasa. That would be about I don't know how would that be in miles, but more than 1.5 miles, something like 1.5 thousand miles. So you need to ship those vaccines to the place. So sometimes we do not have enough vaccine to vaccinate everybody. So we need to target places, to target all most exposed people, and we provide vaccines to them. This is first thing. Second is vaccine hesitancy. We need to work hard to tell people the importance of vaccination. Actually, when I got vaccinated, it was in open place so that people could see that we are getting vaccinated, and they say, okay, these people who are proposing this vaccine to us, they get the vaccine themselves, which that was part of the thing we need to do. So again, the idea is to have everybody vaccinated, but sometimes we do not have enough vaccine, so we need to target most exposed people. Yeah.
Thank you. Thank you so much, Doc. And I know we have three people on the line trying to ask questions, starting with Judy, but let me go back to Bahati. Do we have Dr. Nancy's, Dr. Alice script ready yet? Okay, I will take one more question and then we'll go to Dr. Alice to do a presentation. Judy, I know Dr. Sengi answered one of your many questions, your two other questions. So would you take it from there?
Yes.
Judy,
I'm from Cincinnati. I just had a question. How long does it take for the vaccine to be protective? And if you mentioned it, I'm sorry if I missed that.
All right. Do you have any other question? Is that the only question you have? Because
Well, I
think...
had the map, I think.
Okay.
And I just wondered what triggered this outbreak.
Okay.
Yeah.
All right. Okay. And Marianne, do you want to add your own question to that so the doctor can pick all three at the same time? Marianne Okoye? Sister Okoye? All right. All right, doctor, you can go ahead. I think we haven't heard from Marianne.
Dr. Alice, my computer did froze, so we are trying to restart it.
All right.
I think I can start,
Okay.
and then you find us on the way.
Okay.
Does that sound good?
Yes, please. Thank you.
All right, so we can wait.
Okay.
All right, go ahead.
Yeah, go ahead, please.
All right, thank you. Thank you, everyone. We are sorry for the technical fault. My work has been made easy by Dr. Sengi's presentation. So I'll talk about the 2026 Ebola outbreak, mainly focusing on lessons from the front lines in Uganda. I have already been introduced. And in my presentation, there was a picture of our laboratory and the library, signifying that our multifunctional lab is able to test for COVID-19, Ebola, and any other communicable disease. And then the results are kept in the library for access to students and visitors alike. So where do we stand, you know? And if my slides were brought in, you would see the pictures of health workers really dressed. And I say falsely, because when you are dressed without proper disinfection, you think you are safe. So Uganda 2026 outbreak is almost the 7th outbreak that we had in this country, but all of it was really done. So what do you need to know? The important thing, as doctor says, is you need to know the strain. Some strains are more dangerous than others. And we are happy that the current Ebola situation, the Bundibujo type, is not as bad as the others. And then you need to know the epicenter. Where is the outbreak? Which community? Which home? And then from that, you make follow-up. And thirdly, it is also important to know the case fatality. How many people have died in the community? I want to leave you with this slogan that outbreaks begins in villages. It is never in the hospital. And we must carry that as #1 slogan. And another very important question that I am sure some people will ask is, why does Ebola keep returning? You know, we also used to wonder before the year 2000 when it spilled over to Uganda, that why does it keep coming in the DRC? Because the Ebola that we had in Gulu in the year 2000 was actually also imported from the DRC. It was a soldier who died there, was brought to the community in Ruorobilo, and the communities wanted to know whether that was their real son. And when they touched, and then the infection spread. So how do we answer these questions? There are 3 main root causes. #1 is ecological. There is serious deforestation. And you know, with deforestation, there is more contact of human to bats, because we believe that bats are the agents for transmission. Secondly, it is structural. I heard the doctor talk about our rural clinics. Most of our rural clinics lack protective equipment, personal protective equipment. And when they come, most times there are even no disinfectants. And then in the picture in my presentation, I had put in where they have the sink, but they are also pouring water using a cup that probably has been touched with an infected hand. And then the labs are not well equipped with reagents for testing and for other things. And then the technical staff. Many of our rural health facilities, you will all agree with me, are managed by semi-technical staff or sometimes staffs who are trained on the ground. Then the third one is social stigma. If I go to the unit and tell them that I have Ebola, my community will reject me. So you pretend that all is well until when, you know, nothing can be done. And that has been an acceleration of the spread. Yeah. And now we can ask, why is Ebola stopping in Uganda and not anywhere else? You know, in West Africa, it couldn't stop until when we went there with our model that we designed by ourselves, and then it went because WHO was there and they were not able to stop it. Sometimes it is very difficult for us as health workers to prick our own eyes. But I think this is the time that we must tell the truth and work out where we don't know. We must actually accept that we don't. Yeah. So, number one, the Ebola outbreak in Gulu in the year 2000 should be an eye-opener and lessons for all, because the sanitization with alcohol was learned from here. And we got it from the rural community because when we didn't have disinfectant, they told us since time immemorial, they have been using the Nguli. Nguli is a local brew, which is about 40 to 70% ethanol that is in. So we had to buy the local brew and use, and then also train them to use. And we found that it works, you know. And unfortunately, the patency has been taken away from us before we could even patent it. But this is traditional knowledge that scientists are picking and not taking back the benefits to the community. Secondly, early detection. Where is the point of care? I said the point of care is the community. Early detection is in the community and not in our hospitals. By the time they come to the hospital, it is too late. So that means that we need to strengthen our public health outreach into the community, even when there is no epidemic. And trust is a best commander, and it is discipline. You had in the DRC, they were banning health centers, they were beating the health workers. It's because of lack of trust that they are desperate, they feel helpless, and us as health workers are not giving them very clear information. And then thirdly, the linkage. You know, we need to be with our community, do what is called community-based participatory action research. Our communities have structures, like in Acholi sub-region, we have the cultural leaders, Ke Kwaro Acholi elders, and then we also have the faith leaders. In the epidemic that broke out in Gulu in 2000, they helped in changing the burial processes. They told the community that you know, that this epidemic is GEMO. You know, like viral infection, they say GEMO, bad spirits that has come. So what we need to do is we need to chase it away. So you allow them to drum and beat. And in this particular case, even the mad people knew that something dangerous was already in the community. And they were all frightened and they tried to take care of themselves. And then they give us their measures. And their measures are actually not quite different from the measures of WHO, except that it is not translated into science. For example, they will tell the community that not going to fetch water before 10 o'clock and also after 4 o'clock. Why? Because before 10 o'clock, the sun is still mild. And if someone with an infection spat on the way, you'll step on it and bring infection at home. But after 11 o'clock, the sun is above 40 degrees and it can kill anyone, any infection which is exposed to it. Likewise, at 4 p.m., the sun is going down, so it is cool. Now, if you give that explanation, scientists will understand, and even the community will understand. And what am I saying? I'm saying that we need to work together as a team, because in the community, there is what is called ward query. These are someone who is the Minister of Agriculture and Minister of Health per village. And you know, one village has a certain number of homesteads, and they know each and every person. And if someone is ill, they get the rumors. And basically, they also try to help using herbal medicine before referral to the nearest health facility. Now, what stops the outbreak again was traditional leaders who were made as surveillance, you know, like the village chiefs. You go around, you know, drumming around and meeting the community. And whoever is sick, an ambulance is called and they are referred straight to the hospital, whether it is Ebola or not, you know. All cases during times of epidemics must be handled in the facilities. And what is the take-home message? The take-home message is that it is very important to honor and adjust to the traditional structure of governance if we want acceptance and we want to succeed. Now, where are the research gaps? Oh, I'm glad it has come. Now, you see these beautiful girls enjoying because they say, well, in few days we will be free from Ebola. But what is the research gaps? In history, I think my good friend, the doctor, was saying that the vaccine for the Ebola Sudan strain has not been made. Why? It's because donors come in because they fear that it will spread into their community. But the moment it is contained, instead of going further and saying, well, let's make this vaccine, and in case there is any other attack in any other place, we will use it. They don't, they leave it hanging. And we also leave it as if there is no next time. And then we have these indigenous plants. I am actually also proud to say that during the first epidemic, the elders told us, when we get epidemics, these are the plants that we use. We got them formulated, standardized, and was using it in our wards. Unfortunately, those days, traditional medicine was demonized. So when they asked, we were telling them it was ORS. And when they give ORS, it wouldn't work and reduce the fever. But we were doing it. Now, sometimes funding the outbreaks, you fund and then you disappear when the outbreak is over. So what we are saying is that global priority is favoritism, which is not good. The local knowledge needs to be included in the laboratory as well, because it helps. We need to translate that local knowledge. Justice means research equity. And that is this our fight. And what are the lessons that we have learned? So we need to embrace community trust, because community trust commands and control everything. You know, you control the outbreak because they know it, they understand. We need to work as partners and together. We need to involve the local leaders because they can shift behaviors. Here they say people who died during epidemic is not buried at home because it causes more death. So a burial ground was separated, and then a burial team comprising of the military, the police, the community, and the health workers were designed. And when they die, they are taken and their names are marked in the name that when the epidemic goes, you can visit your loved one. And apart from that, the local community believes that when you recover from epidemics, then you cannot be infected again. So what we were doing is training them and using them to nurse the infected people who were brought in. They were not fearful because they passed through the same, and the care was very good, you know. And that time, no one knew whether it was the health workers handling them or it was the community. And they were our frontliners because they knew how to manage outbreaks and epidemics, how it's traditionally done. But the end result is we want survivors. They also want survivors. And that is how our survival rate was very, very high. There is also really like we need to include traditional healers because it reduces cost and it bridges science and tradition. Because most of this knowledge, medicine actually started as a traditional practice before we modernize it. So there is need to look at where the gap is and where we can bridge for the good of all. Yeah, and we need to take it that Ebola is a mirror of equity, and charity just responds to Ebola. It should respond even when Ebola is not there. It should respond to prevent it. And how? We need water. Whether Ebola is there or not, we need water to fight waterborne diseases, etc. We need staffing, and research equity must be a continuous thing. We shouldn't wait to get epidemic, then we say we are running around. We should prepare and prevent. This is a 21st century, and it should be prevention, 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 and we will save more lives. Now, what is the call to action? Now, a call to action is for faith and justice. We need to fund before the outbreak. What am I saying? I'm saying let's equip our district laboratories. You know, they must be doing outreach, community outreach, even when there are no outbreaks. They must carry mobile clinics into the community to look for what they haven't had, to prepare the community. And really, I demand research equity. Why? You know, like preparing vaccines, vaccine trials should be a continuous thing. Doctor can do it in the DRC. We can do it in Uganda. We shouldn't wait that it should come from abroad. We have the capacity. We have the knowledge. And this is why it is our fight and lessons now. It's us who can fight and save our people. We are not waiting for survivors. We are looking for partners to support us in this. Now, not all is lost. whereas I have spoken so much, there's usually gaps and grace, like the personal protective equipment. Even if you don't have, so long as there are disinfectants and the medicines, be it conventional or traditional, it must be there, will save the lives. I fought Ebola without the personal protective equipment. If you can go back to CNN pictures over there, we did it, we made it, because PPE sometimes is false. You have a false belief that you are safe when the infection is all over your attire. We need those IV fluids. It must always be there. And if not, we need the production unit. In the past, production units used to be within the health facilities with pharmacy technicians manning the unit. We should go back to the past because then it was saving life. And then avoid stockouts. You know, we shouldn't wait that only when there is epidemic, then the donors bring in the things, and when they are gone, they go with the things, and then we begin those bad lives again. Now, we need to empower our women. You know, in Uganda, we use the women groups because women are very powerful. They can talk to their husband, they can talk to their community, they can guide. So they prepare food for those who are on quarantine and also on the ward. And they also benefit because they are paid and it proves onto their economic status. And they wouldn't go back to the community telling them that let us fight these health workers, let's beat them or ban the health facilities. We work with them as partners. And mind you, in Africa, Uganda inclusive, and the DRC, there's basically like one doctor to every 25,000 people. Now, how does one doctor control the community? When we go back, we need to take the message that whatever resources that we get, we need to begin now from down going up, because the approach had always been up down, which has failed to work, and it's killing our people. Here we have border riders. Border riders are local transporters. They transport people, they go everywhere, and they know whom they have transported, sick or healthy, and they can inform and direct you where they are. You note that there was an Ebola patient suspect who disappeared, you know, and the picture was put everywhere. It was the border riders who actually helped the ministry to trace where he had gone. And these are very important people who should be our partners. And then rumors, you know, rumors usually outpaces, you know, the test results. So it is very important to let the community know exactly what is going on, because not all clinical signs and symptoms of passing out blood is Ebola. It can be anything, even cardiac failure. So they need to know. And finally, the churches, because everybody is attached at least to a place of worship, they should be made community hand washing stations. And this is what it is here, you know, and schools. There is a picture, there are pictures I shared with Mr. Bahati of school children. In Uganda, we have trained them to behave like us, and they do well. They check in the dormitories, and we have not closed any school. There was no need of closing schools because there is awareness, and then they also inform their parents, and when they inform their families inform their families, and everyone in Uganda is actually aware. And community awareness is key to fighting any epidemic. And then, what is the hard truth? Because I kept on saying that there is a hard truth. We need to stick to the truth. And the hard truth is that we know how to stop Ebola. You heard even the doctor saying, we know. But like in Uganda, we have done it 5 times and we say we know, and then the people also hire our expertise, and now we have moved into the DRC, that let's do it from there because they are coming to look for medicines from us. We are taking it to them. But what we lack is not knowledge. From all our presentation, it is not knowledge. It is the sustainable investment in the community laboratories, community engagement, community-based participatory action research is the keywords that I want us to take home. And more so trust, Trust, if we have trust, we can fight anything. And future directions. What is the future directions? We need to all recap, do the recap of the Gulo Ebola of 2000. Yeah, because it was a deeply engaged approach. That time, the internet was not as good as now. There was Google, but not as good as now, where you would find people's research. We had to explore and do our own model. We did our model on our own. And now we have the National Committee of Ebola, and then we have the regional, we have the district, we have the city, we have the county, sub-county, the parishes. So all down up to the family level, everybody checks on the other. When you give the information, it really goes. Typically, recently, I went to Omiapachwa. Omiapachwa is in Agago district in northern Uganda. And there was a measles outbreak, and the health workers had not known. But when the community knew that I was from out and doing research, they came talking about it. Immediately, I called the Ministry of Health, and something was done immediately. And we need to encourage systems that work. So by decolonizing the science of healing, we can preserve our cultural heritage, which is very good as far as managing epidemic is concerned. We need to enhance healthcare outcomes. My word, prevention is better than cure. And then we need to foster a more inclusive. They get shocked and then they rebel. So the future direction and plans for continued community, I say university here because we are the people who do research, engagement, and co-creation of knowledge and managing research should be in our hands. We shouldn't wait for donors. Whatever resources which is there, we should continue and envision the future of a healthy population ahead. And finally, my appeal is let's embrace the wisdom of indigenous knowledge and work together towards more equitable, sustainable science of healing. Now, it is good when in the future, after making a big breakthrough, we go in to celebrate our success with the international community when they come to our community and there is no infection of any kind, our people are healthy. Although this requires some patience to arrive at the required standard, but it's not a saying that we shouldn't start. This is the time we must start. Like here in Gulo, sickle cell is killing a lot of people. And if you look at the percentage in Uganda, particularly northern Uganda, it is at 23.3%, which is really so high because it is a very expensive disease to manage, and it takes away the health baskets from the other conditions. So at Gulu University, we are looking at alternative that is the herbal medicine that can probably cure, treat, and manage sickle cell condition. So far, the progress is very good, I must say. We are doing what is called the clinical observation research, where the clients come because herbal medicines have been used since time immemorial. And they are also very lucky that we can, through the laboratory, formulate and standardize and give them a standardized form. We have managed to try and improve onto their quality of life. And in August, when we have the African Traditional Medicine Awareness Week that begins from the 24th of August to the 31st, we will then make more announcements. And it is on a good note because our studies have come up with some molecule. One of them was discovered in 1896 and nothing was done about it. And there are also several molecules which have not been discovered, but when we look through it and try to look at the structures, it is promising that for the first time in Africa, Uganda may come out with something very good. So we invite you, if you are interested, you come and be part of this celebration, see the exhibitions which are going to be there. There are going to be several abstracts, seminars, workshops, and conferences which will be on. So please come one, come all. I thank you very much for listening, for community transformation. And I say all this for God and my country, Uganda. Thank you again.
Thank you, Dr. Alice, for your presentation. Before we go to the Q&A, I would like to really honor our health worker heroes, those who died in the past fighting outbreaks, those who are dying right now fighting these outbreaks, and those who are still alive fighting this. This is a war. Many times we don't think them as heroes. We look at the soldiers with guns, but these people, as Dr. Sengi said, he was terrified in that war. Dr. Alice worked without PPEs. So these are people who just give their lives just to save the lives of others. So thank you for your service. Now, question and answers. We're gonna raise our hands and I will go by the first hand going forward.
Yeah, excuse me, may I say something? I have another meeting actually about the outbreak, and they say me I have 10 minutes, so I have only 2 minutes I can sell this meeting. I'm really sorry, but I need to move in 2 minutes. Sorry.
Yeah, go ahead if you have any closing remarks, and now you this is your opportunity. Thank you.
Yeah. What I will do, thank you very much, is answer to the question that was asked to me just before we started, and that before Dr. Ali started. Actually, thank you very much for this so informative presentation, Dr. Alice. It's very, very useful. So the first one was what?
Oh, I'm
Hello?
sorry. I think Arthur was also said the question was for you, Bati. Would you let him ask so that he can add it to you and then you can answer all of that? There's one person who was asking question directly for you. He's Arthur.
Okay.
Would you mind?
I can.
Bati, I'm sorry. I'm sure you missed that.
Arthur, can you go ahead and say the question?
Oh,
if you are on.
Yes, of course. So my name is Arthur Queiroz. I'm with the Africa Faith and Justice Network as well. Thank you very much to both of the presenters today. I found it very informative. Dr. Alice, your insights about the hot sun being a barrier for people to fetch potable water, which hinders the medical facilities, as well as the research gaps with the indigenous plant use to treat the fevers, I thought were both very fascinating. My question is to you, Dr. Nsengi. Close to the end of your presentation, you showed pictures of the healthcare workers live on the scene, helping to stop the spread of the infection. And I believe you mentioned that at one point you were fearful of your life at night because you felt like someone was going to kill you. I didn't quite hear the context behind that, and so I was curious if you could please speak a little bit more about it, and also what are the health risks that the healthcare workers face apart from just getting infected with the Ebola themselves? Are there any sociocultural risks or barriers, and is that preventing people from entering the profession? Thank you.
Dr. Sengi, you have the floor.
Yeah, thank you very much. Actually, yeah, the question is I'm going to start with the last question. Yeah, because unfortunately, sorry, I didn't talk about this other issue, which is the presence of so many armed groups in those provinces. So if you allow me to share my screen, I can share the current. Okay, let me show. There was also a question about that, so I can, where is it? Yeah, here it is. I took it. So can you see my screen?
Yes.
Yeah, this is the last situation I can find. There is another one that is upcoming. You see those three provinces affect. This is the Ituri in red, North Kivu that in blue, and in green, South Kivu. So we have most of the case in Ituri, 563. We have 32 cases in North Kivu and only 3 cases in South Kivu. The death rate is about 19.2. And if you want a map, I have it in previous reports, so you can see here. Kinshasa is here. And we have about 2,000 kilometers from here. This is the Ituri province, Northern Kivu and Southern Kivu. These are the places where the disease now is. The current outbreak started in Ituri, actually. So in this region, we have also thousands of armed groups that are killing people. We have rebellions, etc. So when we go to treat people, sometimes even the health professionals are attacked by armed groups, and some of them were killed by those armed groups. Some of them claim to be I would say the bad face of Islam, trying to have people converted to Islam by force. And I don't know much about that. I'm not a politician, but yeah, you can understand the context in which we have those armed groups. And but this is not very common. We could have some communities, very remote communities, who don't accept those kind of treatment coming from far away, and sometimes they can be violent. But this is very rare. And especially when we consider that we work with specialists in social culture, in psychology, and all those guys have been very, very helpful to help us understand the customs and be able to have this community engagement around this intervention against Ebola. So the other question was why we have this Ebola outbreak. So we don't have. I don't know the answer. Maybe somebody else have the answer. But and I saw that also in the presentation from Alice. We have a growing population in DRC, and even in the village, people are growing and are growing toward the forests. Villages are expanding in the forest where we have those wild animals which are reservoir for these diseases. And this is why we are having this kind of outbreak, not only Ebola, but also Mpox and all and other diseases. But there might be some other factors which I do not know, but this is what I can say from what I know by now. About the vaccine, the vaccine, what is known from now is that when you get the vaccine, you will be protected about 10 days after you've been vaccinated. Maybe the maximum protection is about 2 weeks after, but 10 days after, you can be allowed to travel to those places. And up to now, we do not know for how many times the vaccine protects. But what has been shown is that the single dose we receive from that vaccine protects for more than 5 years, but we are trying to see how many it lasts. So we do not have an answer yet. But we need to consider that this vaccine is only effective in the Zaire strain. The current Bundibugyo strain, the Sudan strain, the vaccine is not effective, and we still need to find a vaccine for those other strains of Ebola. Yeah, so this is what I can say, and I thank you all. It's been a very great honor to be with you, to talk to you all, but unfortunately, I need to leave. So I apologize for that. I have another meeting actually just about this outbreak. Sorry to leave so soon.
Thank you. Thank you so much. Those who want Dr. Senki to come back and give us an update maybe in a couple of weeks, please put your thumbs up and we will see how he can come back and update us. Thank you so much for your time. We are going to continue the conversation with Dr. Alice.
Thank you. Merci.
Thank you.
Now, Mary Ann Okoye, go ahead and ask your question. Unmute.
Thank you very much. Can you hear me?
Properly.
Can you hear me?
Yes.
Okay. Thank you for the presentation. I'm Mary Ann Okoye from Nigeria. Listening to this presentation, I began to think, in terms of what could the government do of these much affected countries? Is there a way to advocate for the governments to begin to make move to get some kind of license from the countries that provide these vaccines? Because from the presenters, the vaccines are not always available, or maybe not available in enough quantity, or by the time the vaccine has come, the disease has gone far. Which means it is not locally made. It is not locally available. So is there a way to make AFJN or other humanitarian organizations, because I see that the people who went to treat in some places have this USAID on one of their posters. So is there a way that humanitarian organization can be involved to advocate towards these governments to get some kind of licensing, even if it's voluntary license, in order to enable the countries, the other countries, the Western countries who have the patents of these vaccine to collaborate with these countries like the Congo, like the Uganda, so that these vaccines could be produced locally?
Thank you.
That's one question. Second question is this: what about the universities? Because one of the presenters is from Gulu University, where I think he's working in the pharmacy department. When these new discoveries are left just at the level of herbal medicine, it may begin to seem fishy, begins to seem fetish, begin to seem unscientific. Is there a way to coordinate, even to coordinate other African countries, universities, to join in the pharmacognosy department of this university to turn some of these local things, local remedies, into a scientifically approved ones? Thank you.
Dr. Pauline Muchina, ask your question, and then we go ahead and ask Dr. Alice to answer.
Thank you so much, Africa Faith and Justice Network, for hosting us. And also thanks to everyone from Advocacy Network for Africa. My name is Pauline Muchina, and I am from American Friends Service Committee, and I chair the wellness group with AdNA. And so we are very delighted. Alice, Dr. Lamwaka, I would like you to share with us what is happening now without USAID, or without the kind of funding that was available before for Ebola. Can you talk about the impact of USAID demolition on your work, or if not USAID, all global contributions, because I know there are many that have begun pulling back. And then I would really like you to highlight the role of community health workers in all of this, and the role of the faith-based organizations, because they do a great deal. And I want to say kudos to you for pushing the traditional interventions, especially herbs, and if they are scientifically recognized, that would be very, very helpful. Thank you.
Thank you. Dr. Alice, also, if you don't mind sharing your experience, your intervention in the West Africa outbreak. You have the floor.
Okay. Okay, thank you. Thank you very much for all your questions. I'd like to begin from the point of the question that was asked. Uganda share a little bit with DRC that it also had rebels during the time of the insurgency. We had an insurgency when Ebola broke out. So the key thing that one needs to do is to broker peace. No fight during that period, because Ebola does not select, it takes all. So rebels in Uganda were very understanding. They were also finding cases and referring, meanwhile keeping to their zone. So government intervention and traditional leaders' intervention and the church leaders' intervention on agreeing, like I keep saying, trust, 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 and truth, worked the miracle. And they began the fight again after Ebola was gone. Now, what do government do? Like sometimes when I speak that, any time I don't believe so much in vaccine, because you can't say that if one particular thing is not there, then you cannot act. Adjunct therapy, is what you can do. Like in Uganda, we sat down as specialists and looked at the disease itself, and then the complications that come along with it. So we went in to prevent complication and improve onto the quality of life. And a very easy thing with Ebola is, it dies by dilution. So if you give in IV fluids, that's why IV fluids therapy is very important. We did that. And then still, I repeat about making our African solution the discovery, because they say the discovery does not work. It does work. Like during the COVID time, I'm one of those who innovated COVID from herbal medicine, and it kicked out, I think, COVID from most parts of the world, for those who came and took the medicine and the disinfectant. So we should not underestimate and underrate our products, our traditional medicine, because most of this conventional medicine came from traditional medicine. Like the penicillins came from our mushrooms, the local mushrooms. Quinine came from our chinchona tree, etc., etc. So, there is a lot that we can do with our biodiversity. What discourages most people is biopiracy and restriction on intellectual property. That, African government must work on. So I have to share what is happening without funding. Fortunately, in Uganda these days, we don't rely so much on foreign funding. Our president is very passionate about traditional medicine, and there is support that comes from the president's office for research and a lot of it. So we use that for working. And donation had no impact here because the areas where they were funding, it was merged together with the traditional Ministry of Health practices. So it wasn't felt. What was felt was that the staffs were not getting their allowances, but they were getting their salaries. So we moved on. And then in Uganda, they have built hubs for basically doing most of the things as far as traditional medicines research is concerned. We have very good laboratories. Example is ours, which was shown on the map. I asked Mr. Bahati, go back, I think it is the second or third slide, to show them our multifunctional lab. In that lab, we have a lot of sophisticated equipment, and we are able to do biochemistry and chemistry tests and biological tests. Also able to separate aflatoxin. So we are able to do a lot. Then we have a laboratory at Makerere, the veterinary department, where they do safety and efficacy. They do toxicity studies. And then you can Google the Lung Institute at Mulago Referral Hospital, where we do our clinical trials at the expense of government. So not all is lost. When I was making our presentation, it was in relation to African countries, our neighbors. And besides that, you know, as Uganda, we want to do Bobo. We want to do made in Uganda, buy Uganda to build Uganda. So we are very reluctant to partner with other organizations that will say, for instance, I was very proud to announce that we have our molecules that we are likely to be the first in the world to get a cure for sickle cell because of biopiracy. So as Africans, we need to partner amongst ourselves and look into the practice of collaboration and coordination. What you have, another may have, and then we work like that, and the sky will be the limit. Basically that. And finally, you are talking about the faith-based and NGOs. You need to have a coordinated approach. And in Uganda, the Ministry of Health is the lead, and they bring in partners according to the need. And then they work through committees, as I said, and that links from the national level up to the, you know, our parliament up to the villages. Thank you very much.
Thank you so much, Dr. Alice. I will call on our Executive Director, Stephen, to share last thoughts, questions, and close this meeting. My name is Bahati. I'm a policy analyst with the Africa Faith and Justice Network. It has been my pleasure to moderate this panel. Thank you, and up to you, Dr. Stephen.
Thank you. Thank you so much, Bahati. And we almost, this event was slated for 12:30, so it's like 1 minute towards the end. But I promised to just read a few questions that came up on the chat. And many of them, you and Dr. Senga may have answered them, but if you feel like there's something that you need to answer, you probably will just shed a little bit light on that. And one of the questions was from Isabel Izika, who had asked the question, how is the real situation on the ground today? Which provinces and cities are affected? How many people are infected and what is their situation? How many deaths? Some of these I'm sure you may have answered, but I needed to ask that question. The other one was from Moga Kamal. And I think in her response, why should we wait for pharma? Africa does not invest in its own research institutions or universities. Therefore, we always rely on products from the north and blame pharma. COVID was a wake-up call, so I'm pretty sure she wanted to know why we should wait on big pharma. And then there is a question from Nikita. This is the last question that just came in, and I wanted to just ask that. Thanks for this insightful presentation. I like the idea of supporting local traditional cultural medicines. My question is, should those of us in the US going to the World Cup matches, watch parties, have any concerns about coming into contact with anyone who may have traveled to countries impacted by Ebola? I'm sure this might be in the minds of many people who are coming, who are going to watch the World Cup. So that's really much ending on the lighter note. So, Doctor, I don't know if you have any response to any of that, and then we'll probably just wrap this up and thank our audience. To you back, Dr. Lamwaka.
What can I speak?
Yeah, maybe if
Hello?
yes, Doctor, we'll listen.
Can I speak? Yeah, so basically all those questions I think were answered.
Mm.
Yeah, apart from really like the numbers, for Ebola 2026, I would say that the case fatality in Uganda was 0 because all the cases were imported from the DRC. And then you had the permanent secretary instructed the health workers to actually set up mobile clinics within the border and inside DRC. Yes, so if you want to know that, that is that. I can't talk about the case fatality in the DRC because I am not linked to the Ministry of Health there. And per se, if we talk about the Ebola of 2000 that hit Gulu, the mortality rate was the lowest in the world because at that time, really, when it comes, it was almost like you get a 99.9% fatality rate. But then we really cut it short. And even now, the subsequent ones that was coming, the survival rate was very high. It was more than 70% survival rate. And the 70, it's like because of dealing with small figures, if you factor it in to the population of about 45 million people. So we would say that it is negligible because this percentage here was basically like measured on who was there and how they came and all that. So because we know the management, that is why we don't fear going to give consultancy in the different countries. We went to West Africa and we managed to kick Ebola out of West Africa. And even in the Sudan here, you know, you haven't heard of those cases. And we believe that really if condition conducive, using our model as a country, we will also be able to kick out Ebola from the DRC. I think at one time we were also there and it took a very long time before the next outbreak. So this time we want to kick it out so that we go into our normal economic activity. And the key word to all of us here should be prevention, prevention, prevention. And if there is any aid that we should get, that is in case we have donors on this platform, is for them to send money for research and also to do community engagement for prevention because it is cheaper. The other monies can then be diverted into economic development for the country. Thank you.
Thank you. Thank you. Prevention, prevention, prevention. And with that, we end this very, very informative session. And thank you so much, Dr. Lamwaka. And we also want to thank Dr. Sengi, who has left. You guys are on the field and you provide very valuable work there. And one of the things that I take from this, like you said, what we lack is not knowledge. I think that's very important. And you were able to show that. You are a hero. I want to thank you. I want to thank Dr. Senga and for the invaluable work you're doing. And on behalf of the Africa Faith and Justice Network and our partners and in this work, and the AdNA, the Advocacy for Africa Network, I want to thank all of you who have attended, our board members, our supporters, and people who are very, very much interested in working for and with Africa. Thank you, and you have a blessed day. Bye-bye. And thank you, Bahati, for steering this meeting. Thank you, Doctor. Bye.
Thank you.
God bless.